Hi there, this is Annie. I'm a fourth-year resident with anesthesia at Western University. Currently, the talk for this neuroanesthesia rounds will be on mechanical thrombectomy and the neuroanesthesiologist. Overall, this presentation I hope to cover management and kind of patient population of elective and urgent carotid endarterectomies, and then progress to more urgent procedures such as endovascular thrombectomy for acute stroke, and then talk about the controversy between general anesthetic sedation for stroke thrombectomies, and then we'll talk about a paper, specifically this 2020 paper, that looks at general anesthetics, sedation, as well as local anesthesia for stroke thrombectomies. And then very briefly, we'll take a look at COVID guidelines as per SNAC, published over this COVID pandemic. The first paper we'll look over is the Society for Vascular Surgery paper on patient population selection for carotid endarterectomy. This is a paper published in 2022, so it is quite recent. Looking at indications, and the ones I put on the slide are grade 1 recommendations for patients requiring or should be having carotid endarterectomies. So these patient populations are grouped into asymptomatic and symptomatic patients. For asymptomatic patients, they do not recommend routine screening in this patient population. However, for whatever reason, if they were determined to have a carotid stenosis, they do recommend that the stenosis be greater than 70% prior to surgical procedure. And of course, that the patient population and the risk of surgery should present itself as low risk. Of course, with all surgical procedures for carotid endarterectomies, the patient should also be on medical therapy, because without it, the risk of stroke is very high. The second group of patients is your symptomatic patients. So this would be patients with previous strokes or TIAs, or if they have a carotid bruit. So for low risk and standard risk patients with greater than 50% stenosis of their carotid artery, there is a recommendation to undergo carotid endarterectomy. If the patient is recently post-stroke, they suggest that carotid endarterectomies be done between 48 hours to 14 days after symptom onset, and to ensure that the patient is neurologically stable. And neurologically stable refers to a modified Rankin score of 0 to 2. Contraindications for carotid endarterectomies usually fall in the post-stroke population, and these are people with disabling strokes with a modified Rankin scale greater than 3, or whose infarction area is greater than 30% of the ipsilateral cerebral artery territory, or those who have altered consciousness. However, these patients, of course, within the 14 days should undergo re-evaluation, and should their neurological status improve, they can undergo carotid endarterectomies. Looking quickly at the medical management of patients with carotid stenosis, I think this is quite interesting in the sense that this is how the patient will present, and this is how or what kind of medications these patients will be on. So still relevant for anesthesiologists. In terms of risk reduction, there are a few goals for these patients. They include smoking cessation, and this includes passive smoking as well. Their dyslipidemia should be managed, and it should be managed aggressively. So this would be starting a high-dose statin, and then a cholesterol chelator if the statin is insufficient. With the statin, what's relevant to anesthesiologists would be that screen for statin-induced myopathies, and this may present itself as weakness in these patients. In terms of blood pressure control, these patients will likely be on an ACE-I, and for patients younger than 65 years old, their target blood pressure overall is less than 130 and diastolic of less than 80. So for us, again, the ACE inhibitor, usually we do discontinue it in the preoperative period. Preoperatively, so the day before surgery. I think this is still relevant and should continue to be discontinued for better blood pressure control in the OR, because these are long-term studies. Missing one dose should not be a concern or impact on mortality. These patients will also be on antithrombotic therapy. There has been evidence for single antiplatelet therapy with an ASA of 81 milligrams that reduce risks of MACE in asymptomatic individuals. In other individuals, you may see both antiplatelet as well as anticoagulation manifesting as ASA and rivaroxaban, and both have been shown to decrease MACE as well. For secondary prevention, so those who have already had a stroke, they suggest, or studies suggest, that a single antiplatelet therapy is better than oral anticoagulation, and DAPT may also be used in the early phases post-ischemic stroke. And this will be a short-term use of 21 days. So for people who have had strokes and are neurologically stable, these patients will likely come to us for carotid endarterectomies with this DAPT on board. And this is usually for people who do not receive thrombolysis that will receive the DAPT. For people who have received thrombolysis, we'll likely see just an aspirin afterwards. So after they've been cleared of hemorrhagic transformations post-stroke. After carotid stenting as well, these patients will be placed on DAPT for a period of time. Looking at this graph, which I think is very interesting, you'll see that on the y-axis you have stroke, TIA, carotid revascularization, so kind of endpoints for carotid stenosis. And then on the y-axis on the right side, or in orange, you notice that this is the progression of carotid artery stenosis. You'll see that here are the 4 criteria or categories the authors looked at, and they look at smoking, blood pressure control, so smoking cessation, blood pressure control, cholesterol control, and whether they're on statins. So if none of this have occurred, so because these are otherwise, so this is smoking, so if yes, they're still smoking. So if none of these categories are controlled, it'll be marked as a yes. You'll see that their rate or incidence of any sort of end events from a neurological point of view or surgical point of view is quite high at 3.5% compared to the group on the right, which says, oh no, the incidence of neurological endpoints with carotid stenosis are just above 0.5%, and a similar trend is seen with carotid stenosis progression. Therefore, this shows that medical management is a must, and then once you've reached a certain threshold, surgical management will be beneficial. Going on to talk about intraoperative goals for carotid endarterectomies. So goals as per Miller is to protect the heart from brain, protect the heart and brain from ischemic injury, control heart rate and blood pressure. They suggest that if there is contralateral stenosis of the carotid artery, when they clamp, to induce hypertension by 10 to 20% above baseline, and this is, we're talking about MAPS. They suggest that if the blood pressure is greater than 200 millimeters of mercury, this is when you start to get myocardial ischemia. Of course, this is patient dependent. Say if the patient had coronary artery disease, they may have myocardial ischemia at lower blood pressure thresholds. Miller suggests to mitigate surgical pain and stress response. Also, the other goal is to wake the patient in a timely fashion such that they may have appropriate neurological examination at the end of their surgery. Critical events for carotid endarterectomies. So this occurs at the time of carotid clamping. If local anesthesia is used, local or regional anesthesia, the patient may experience neurological deficits, and this may be uncomfortable or scary. In that instance, they may require a conversion to a general anesthetic, and then the surgeon may elect to go ahead with shunting of the carotid. But interestingly, the conversion rate is about 2 to 6% from local or regional to a general anesthetic. And of course, it's not fun to be under these circumstances where there is limited access because the drape is over the head area, and it's difficult to negotiate a patient who has their neck exposed, their neck vascular exposed, and we would like to intubate them. However, if we do undergo good patient selection, 92% of patients who had a local or regional anesthesia done for their carotid endarterectomies would be okay with having a repeat of the procedure done under local or regional anesthesia. I would like to note the word choice here. So surgeon may do shunting if they're forced to do so due to poor neurological perfusion, and elect should not be there. It is circumstanced by the amount of perfusion the brain has, and of course induce hypertension at the time of clamping if there's contralateral stenosis in the carotid. Surgical manipulation of the carotid sinus may cause hypotension and bradycardia. There has been a suggestion in Miller to infiltrate the carotid bifurcation with 1% lidocaine, and because you've anesthetized that receptor, there is a concern for hypertension afterwards. However, realistically, or what we most see in the OR, may be that once the plaque has been removed, then the carotid sinus is sensing way more blood flow and way more blood pressure because the plaque is no longer there to act as an insulator, and therefore we may get actually hypotension in the post-operative period, and that we need to control afterwards. In terms of extubation, again, extubation is a time period where many things happen and the patient is returning to their normal physiology, but it is also a time where if there are any neurological deficits determined on their neurological exam, further steps need to be discussed and planned for, and this may be taking the patient for a CT head or a CT head plus angiography and need or at least preparation for reoperation, should any findings be found on brain imaging. So some quick discussion questions. These are difficult, but to discuss. So the first question is, you have a 70-year-old female with carotid endarterectomy with a recent stroke. Their pre-op blood pressure is 210, but they're asymptomatic. Would you proceed or would you not proceed? And this being a discussion question, I will tell you what we did in the OR, and we did proceed because this is more of an urgent procedure as she is post-stroke. And without monitoring, it was difficult for us to tell whether a lower blood pressure would compromise her brain perfusion. Of course, Miller mentioned that there is a concern for cardiac ischemia with blood pressure over 200s. Therefore, in the OR, we elected to use our anesthetics to bring down her blood pressure because it was easily titratable, especially the volatile anesthetics. And this again ties into what kind of antihypertensives we would use. So we elected to see how she did after reperfusion of her carotid. If she did well, we were going to target a blood pressure of 180s to 160s. And we were to use pharmacological means to maintain that blood pressure. However, afterwards, her blood pressure was reasonable and within that target, so we elected to leave her as is. The next question is our 65-year-old male for carotid endarterectomy, and the surgeon asks for a MAP of 100 prior to clamping. So I think this is relatively newer in our institution that I've experienced. I think with this blood pressure target, they are trying to achieve that increase in blood pressure of 20% for a MAP. However, it's difficult to assess what the patient's baseline is. They may have picked an arbitrary number and asked for a MAP of greater or equal to 100. But interesting for that case, our patient was a vasculopath, and it was very difficult pharmacologically to bring up his blood pressure. It seemed like he was not responsive to our vasopressors or inotropes. It may also be that the doses I titrated with or used are very small, such that we did not see effect. However, once they clamped the carotid artery, the patient had or experienced significant hypertension, such that we were using our anesthetics to bring down or to vasodilate. So I think this is interesting, whether or debatable whether it's necessary to achieve a MAP of 100 prior to clamping. I think it may be better to look at in the clamping phase and to optimize blood pressures after the clamp has gone on. And lastly, thoughts on using LMA or an endotracheal tube for a GA anesthetics for these procedures. Of course, it depends on good patient selection. If you have a large patient, definitely it'd be better to use an endotracheal tube, or if you're using a LMA as a backup or rescue airway for a failed local or regional, it is also more appropriate there. But overall, some considerations is that under an LMA, of course, is not a secure airway, and you may lose it during the GA anesthetics and need to convert to an endotracheal tube. Therefore, patient selection and in what kind of context of either emergent conversion to a GA or to start off making the decision, it's important to consider before choosing whether you would go with an endotracheal tube or an LMA. So now we look at some guidelines for thrombectomy in acute stroke patients. So these are patients who acutely present with altered neurological status or deficits and come for thrombectomies. So the diagnosis of stroke, etc., and imaging will be done in the emergency department, and usually a neurology stroke team will be there to assess the patient and ensure that they've gone adequate investigations. The patients, if suitable candidates for thrombolysis, will undergo thrombolysis within 4.5 hours of symptom onset. However, if they've passed that 4.5 hours, they can fall back on to endovascular thrombectomy, which is suggested for 6 hours after stroke onset. If at your institution, or likely at our institution, our interventional radiologists are comfortable with performing late window thrombectomy, which is up to 24 hours, we go ahead and we'll see patients who have been thrombolyzed and are now presenting for thrombectomy within the 24 hours. The recommendation, as per the 2018 stroke guidelines, is for sedation. So sometimes there is a discussion between the neurologist and the anesthesiologist as to whether sedation or GA would be more appropriate. Again, the 2018 stroke guidelines would suggest that patients eligible for both thrombolysis and thrombectomy do have both. And then, of course, they talk about management for further goals of care and further management. This is interesting, I thought, in the updated stroke guidelines. They do talk about hemiorolingual angioedema after TPA. I've not heard of this before, but here it is. They suggest that this progression is pretty quick, within 30 minutes of TPA administration, that they do get swelling, and of course treatment is pretty much similar to any angioedema or obstructed upper airway that we see, and it's kind of stop the offending agent, give methylprednisolone, give some diphenhydramine, and then of course intubate the patient if you're very worried about airway compromise. In terms of goals or things to consider for stroke patients, as per Miller, they usually present to us within 24 hours of onset of stroke symptoms. We may decide to have a GA or sedation. As per Miller, they have so far not recommended one over the other and suggest that they may be similarly in terms of outcome. What they do suggest is that you look at the patient. So if this patient has a rapidly progressing stroke, then definitely would make sense to do a secure airway, just in case the patient deteriorates even further on the table and loses the ability for respiration. The comfort level of the anesthesiologist and the local practice at their institution. Targets for thrombectomy in acute stroke patients is to maintain cerebral perfusion near awake levels, maintain normal capnia, and avoid profound hyperoxia. This is to avoid free oxygen radicals in the brain causing more damage. Intraoperative considerations for these patients is that this is an emergency procedure with associated full stomach considerations. Time is brain, so in this case, it's important to do things quickly, however, safely. We should facilitate a good environment for the interventional radiologist, and this is minimizing patient movement. And we should also, like most neurological procedures, allow for rapid extubation and awakening for a good neurological exam after the procedure. Critical events during the stroke thrombectomy, and this is number one, to decide early whether you're going to go ahead with a GA, general anesthesia, or sedation, but sometimes it's hard to do so until you've met the patient, and this is usually in the interventional radiology suite. So usually we can have both setups ready. For blood pressure control, if this patient is prior to revascularization and TPA has not been given, a target systolic blood pressure has been advocated for 160 to 180 millimeters of mercury. Post-revascularization, there's a concern about blood pressures, and it's important to maintain it or drop it to between 130 to 150 millimeters of mercury, and this is to prevent cerebral hyperperfusion syndrome. And of course, intracranial hemorrhage after the thrombectomy, and especially in patients who have had TPA. During the stent deployment phase, or when they're retrieving the clot, it is important to anticipate that the stent can cause some discomfort and some pain. So you may need a little bit of extra sedation if you're going ahead with sedation prior to the stent deployment. Also, after revascularization, the interventional radiologist may administer some intra-arterial verapamil or nitroglycerin. So at this phase of patient care, it's very important to have good communication with your interventional radiologists to anticipate hypotension and treat that or prevent it from happening. This is a quick summary of what should be done in acute stroke care, and I'll leave it here for personal reading. So now we move on to some evidence looking at general anesthetics or sedation for acute stroke thrombectomies. So this is a randomized controlled trial done in 2016, and what they looked at is more or less, this is called the Siesta study. It's a single center randomized controlled trial, and the population there's a population of 150 in the study. Interestingly though, the stroke location has been limited to anterior circulation. We do not look at posterior circulation strokes, and they look at patients with a NIHSS scale greater than 10. Very nicely done though is that they look at clinical outcomes. So they say that within reassessment of the NIHSS score, within 24 hours, a change in 4 is decided to be clinically relevant. So anything in this paper that's statistically significant will also be clinically significant. So looking here, this is their patient demographics. And because this is a randomized trial, we don't anticipate any differences in the general anesthesia versus the conscious sedation groups. Here is the outcome, and what is interesting is what is significant. So looking here, we look at, so in their primary outcomes being change in NIHSS scale that we talked about before, there is no significance. So their overall finding is that GA versus sedation does not lead to a neurological outcome difference in stroke patients undergoing thrombectomy. However, if they looked at their secondary outcomes of door to arterial puncture time in minutes, you see that general anesthesia is about 10 minutes longer than conscious sedation. We also see that the duration of the procedure time is a little shorter in general anesthesia, maybe due to lack of patient movement, lack of need for patient cooperation. What is interesting though is, well, to be expected, hyperthermia or hypothermia, you see that it is more, temperature is much more difficult to control in the general anesthesia group, simply because the patient is exposed and there is not a lot of time to apply warmers or warming blankets to these patients. Delayed extubation, I think this is difficult to say because only general anesthetic patients are intubated. Of the 5, it's likely a conversion from conscious sedation to GA, so I can't really comment on this. Ventilation-associated complications, you see more in general anesthesia, which I think was pretty interesting because I would have expected the conscious sedation people to have more aspiration and possibly needing ventilation afterwards. So what we see is the ventilation-associated complications is defined as tube-related injury, pneumothorax, ventilation-associated pneumonia, onset after 48 hours, aspiration. But to be fair, they do include tube-related injury and pneumothorax. Maybe this is why you see more patients in the general anesthesia group having ventilation-associated complications. So overall from the study, it seems like primarily, when they looked at their primary outcome, there's no difference between general anesthesia and sedation for neurological outcomes. So Miller cited evidence number 2, general anesthesia versus conscious sedation in endovascular stroke treatment, the AND stroke trial published in 2017. Again, this is a single center randomized controlled trial with an N of 90. Patient population, again, is limited to the anterior circulation. So we have no findings on posterior circulation strokes. And they look at neurological outcomes at 3 months, being assessed by the Rankin scale score. What you see here is findings of blood pressure changes during their anesthetics for thrombectomy, and this is the GA on this column and conscious sedations here. You'll find that with the GA, there is significance for increased drop in blood pressure during general anesthesia. It's any blood pressure fall greater than 20%, and the time spent in that blood pressure fall is also longer under general anesthesia. Interestingly, so on the table here on your right side is the outcomes. And again, very interestingly, we do not see a difference between recannulization success, and we do not see a difference between NIHS score 24 hours postoperatively. Looking at the modified Rankin score, there's no difference at 3 months. So overall, this paper would suggest that there's no difference between GA and conscious sedation in stroke thrombectomy patients. If we look at the anesthesiologist or anesthetics complications between GA and conscious sedation, again, there's no difference, but you'll note that in the conscious sedation, there was loss of airway in 2 patients. So there they would have needed to do emergent conversion to a general anesthetic, and of course aspiration in both groups and hemodynamic instability in the GA group. So these are some things and complications to consider when undergoing a stroke thrombectomy. Miller also cited this meta-analysis. However, there were some concerns with the methodology as in the letters addressed to the editor. Therefore, I've elected not to go ahead and review this paper. So in its stead, I have looked at a 2020 paper of a prospective patient population, and this was done in Italy, looking at general anesthesia versus conscious sedation versus local anesthesia during thrombectomy for acute ischemic stroke. What this paper does, very interestingly, is number 1, you'll note it is a prospective cohort study. It is not an RCT. However, the number of patients is significant at 4,429. The age criteria is all adults. What is interesting is that these authors look at both anterior and posterior circulation strokes. And their outcomes are such, they look at the modified Rankin scale. They label excellent as 0 to 1, favorable as 0 to 2, and mortality, which is death at 3 months. So in terms of their modified Rankin scale, I'll only look at the favorable outcomes because favorable encompasses excellent, and a 2 score on the modified Rankin scale to me is still a good outcome in that the patient are able to function by themselves. However, they may need support after stroke. So this is how they selected their patient. So their initial N was over 5,000, and then after that it was excluded based on their exclusion criteria for adults, for patients that had anesthesia records, and for patients that had thrombectomy. So this is their baseline data or patient demographics. You will see that there is a significant difference between the people, significant difference of NIHSS scores between people who had general anesthesia, conscious sedation, or local anesthesia. And you'll find that the general anesthesia score is poor, however, poor by 1. compared to conscious sedation and poorer by 2 compared to local anesthesia. In terms of how much clinical difference that is, I am not sure. You also find that in the general anesthesia group, you have more patients with vertebral basilar artery strokes, so posterior circulation strokes, and I'd be very interested to look at their outcome for this group of population. Again, so this is looking at time to kind of growing time, onset to growing time, so looking at whether general anesthesia is faster, conscious sedation, or local. You'll find that general anesthesia, again, is about a 20-minute difference from conscious sedation, and then local anesthesia is about a 15 minutes difference from conscious sedation. So this is significant, and procedure time is a little bit longer in the general anesthesia group. Likely, I want to say because there are more posterior circulation thrombectomies in this group, and it may be that this is more difficult for the interventional radiologist to remove. So looking at the outcomes, so this is their supplemental table, and this table is after adjustment of unbalanced variables. So in what I've highlighted, you look at the modified Rankin score. We'll look at this one for 0 to 2 for general anesthetic versus non-general anesthetic, and you'll note that there is a significant finding towards the non-general anesthetics. So in this paper, they suggest that GA compared to non-GA, non-GA is better for a modified Rankin score. However, you do not see any mortality difference when you look at GA versus non-GA. Very interestingly, you'll later see that this non-GA group will be divided into conscious sedation and local anesthesia, local or regional anesthesia, and you'll find that in the non-GA group, it's the local anesthesia population that have better neurological outcomes. And so how they did this was they looked at propensity score matching models, and in total they made up 5 models, as here 1, 2, 3, 4, and 5. And this is what they included in their propensity score matching within each of the models. What I had my sights on was model number 4, because this is where they included site of occlusion. So here is, we can look at whether GA versus sedation has any differences in anterior posterior circulation strokes. So looking at their outcome, again, so this is models 1, 2, 3, 4, and 5. And here is the modified Rankin score. We'll look here because it's 0 to 2, and then we'll look at death. So if we look here, you'll note that there was nothing significant that happened from model 3 to model 4. So it seems to me that GA versus non-GA doesn't make a difference, at least in this study, for posterior versus anterior circulation strokes or thrombectomies. And what you'll see here is they looked at GA versus conscious sedation and GA versus local anesthetics. And you'll see that for the GA versus local anesthetics group, all models show a significant difference. So this seems very convincing to me that patients will do better from a neurological point of view if they undergo local anesthesia for stroke thrombectomy versus a general anesthetic. In the GA versus conscious sedation groups, you'll see that there is significant difference towards a conscious sedation, favoring conscious sedation in model 3, 4, and 5. In terms of death, you'll note again that GA versus local anesthetics, there is a significant difference, and it favors the local anesthetics group. With the GA versus conscious sedation, again, you will see that there is no difference with death. So conclusions overall, it may be, or at least it recommends further investigation between GA, conscious sedation, and local anesthesia for stroke thrombectomy. And that our thoughts about automatically going to a general anesthetic for posterior stroke thrombectomies should be questioned. Here is just for my interest when I looked at this is a 2017 study that looked at monitored versus GA for vertebrovascular strokes for thrombectomy. And what they did was a case control study with N of 122 post-matching. And their outcomes are such that the modality of anesthesia was not associated with any significant changes in the modified Rankin score. Therefore, again, it puts into question whether we should go ahead with general anesthetic for every posterior circulation stroke that we see. Although theoretically it makes sense, however, it's good to question based on these data. Now we are switching gears to talk quickly about thrombectomy and what we expect during the interventional radiology procedure. And this is that mechanical thrombectomy, the success is 50%. How they do it is now there are two main ways of doing it. They can do it by direct aspiration or they can do it via a stent retriever. Sometimes the interventional radiologist may add a little more thrombolysis once they're in the artery. However, this is not usually done. And if it is done, it should definitely be communicated with the anesthesiologist for good control of blood pressure. So this is a quick figure looking at kind of the different types of clot retrieval mechanisms. And the two we're going to focus on is this one, which is the clot retriever, and this one, which is the one that suctions the clot out. So what they have is they have a little guide wire that brings the suction catheter or tubing to the area of the clot, and then they pass this instrument in that will break up the clot as this is suctioning. So this is the suction way of retrieving the clot, and then this is the stent way where they put a catheter in, goes past the clot, blows up the stent or opens the stent, and then pulls this clot out of the artery, and what you see here is the stent and the clot. So again, changing gears, we're quickly going to show you a little bit of guidelines by SNAC on stroke thrombectomies in the COVID era. And as we see here, you have the goal again is optimal neurological outcome for patients. Goal number 2 is minimizing risk to health professionals, and goal number 3 is facilitating judicious use of resources. So looking at the anesthetic technique, SNAC recommends that we make a decision early on. If we are going to, decision in terms of GA versus sedation, to minimize the need to make a decision for early on for GA versus sedation. And then they do suggest that if a patient can undergo a general anesthetic, that we do a general anesthetic to minimize the need for conversion. If we do a general anesthetic, we need to pause the interventional radiologist and have them wait for 5 minutes as we pre-oxygenate the patient for rapid sequence induction. And they, of course, suggest they avoid the use of LMA unless it's a rescue device. In terms of intubation, have your gear available. The patient should wear a surgical mask. Most probably have some gamma decks available as well, because if we're going to do more general anesthetics with rapid sequence inductions, we may want to have the reversal easily accessible. However, if you were to decide to do a monitored anesthetics, they suggest that nasal prongs, the oxygen should not be greater than 5 liters per minute for aerosolization concerns. They also suggest that there's a lack of prediction tools to look at whether a patient is high risk for conversion from MAC to GA. Therefore, again, it's provider comfort and patient selection. Maintaining strict blood pressure control while donning and doffing PPE for healthcare providers is very important for patient outcome. So this is all that I wanted to say in the COVID times is to, if you can, and if patient selection is appropriate, to undergo a general anesthetics, ensure appropriate pre-oxygenation, and have reversals available for emergency situations. This is their decision tree, and I will leave this here for personalized reading. And thank you very much for attending this presentation.